Good evening to each and everyone over here. I'm thrilled to welcome you all for today's informative webinar on endocrine emergencies, acute management, and protocols. I'm Gagana Bellari, manager at Mediversal Academy, and I have the privilege of introducing our esteemed speaker for today, Dr. Alen Thomas. Dr. Alen Thomas, an MBBS graduate from CMC Vellore, furthered his education with a master's in general surgery at CMC Ludhiana. He initiated his career in the resource limited regions of Uttarakhand and Uttar Pradesh, showcasing a strong commitment to excellence. Driven by his dedication, he earned a PG diploma in family medicine from CMC Vellore. Specializing further, Dr. Alen Thomas completed a PG fellowship in vascular surgery, earning FMAS fellowship recognition from AMASI. As a proud member of ASI, AMASI, and CMAI, he is also recognized for his prowess as a presenter, having been awarded Best Speaker at CARES 2022, Ludhiana. Thank you. Over to you, Dr. Alan G.
Thank you, Gagna. Thank you for that introduction.
My pleasure. My pleasure.
So shall I start? Do we have adequate number of participants?
Yes, you
And I
can
hope
start
I'm
the session.
audible and clear to everybody. If they could quickly
Yes.
put it in the chat box, I can start. So
Yes,
today's lecture, I hope it's very meaningful to a lot because these are things that we sometimes tackle on a day-to-day basis, and quite frequently they end up in your OPD, and you have all these different problems that are there. Right. So starting off with endocrine emergencies, this is mainly an overview slide, I would say. Some of the slides I'm going quite in detail, and just a couple of them, towards the end, I'm just brushing up. So I hope it's a very intensive lecture, and I hope to keep your interest till the end. So starting now. So endocrine emergencies, acute management and protocols. So so as we can see in this image, what are the emergency? We have the endocrine systems first. That's a normal thing. So most of these things that I've associated that have some emergencies associated with it. So what are the endocrine emergencies? So an introduction would be an acute and life-threatening conditions resulting from endocrine dysfunction. So what were the endocrine organs? Here on your right side, as you can see, you have the thyroid, the pituitary, the adrenal, pancreas, and left me, I have put in the words of endocrine emergencies. So what are the key characteristics of these endocrine emergencies? So they're rapid onset. So many of them, if you look at the guideline, they say don't wait for the results. It's a mostly clinical diagnosis. If you think those endocrine emergencies are there, immediately assess the symptoms and you have to start the treatment. So symptoms can escalate very quickly and sometimes within hours. So it can be life-threatening. They can lead to multi-organ failure or death if untreated. Now, the management is also quite complex. There's a rapid onset, complex management, life-threatening, and because these are all related to hormones and there are these hormonal imbalances. And that is leading to these emergencies. Systemic effects, of course, even though there are hormones are there in the entire body, it can affect various organs and systems, including the cardiovascular, nervous, and renal system. As you know, these are all the vital organs. So what are we looking at? We are looking at today we'll quickly look at 7 important key endocrine emergencies. Hypoglycemia is on the top of the list, which is seen very much in your emergencies or day-to-day setting, or even when you're routinely traveling or you've not eaten, you feel some hypoglycemic episodes. So hypoglycemia, diabetic ketoacidosis, hyperosmolar hyperglycemic state, myxedema, coma, pheochromocytoma crisis, thyroid storm, and adrenal crisis. So let's start off. So first, we'll look at hypoglycemia. So hypoglycemia, there are 2 categories. You have in patients with diabetes and without diabetes, right? So if you look at in patients with diabetes, all episodes of abnormally low plasma glucose concentration, with or without symptoms, that will expose the individual to harm. That's a very, very simple and basic definition that I've tried to, incorporate. So if you look at without diabetes, let's start off without diabetes. Many of them may not be diabetic, but have the symptoms of hypoglycemia. So you can have certain medications which I'm going to, tell you in the upcoming slides. Certain medications which you take can cause hypoglycemia. Alcohol definitely can cause hypoglycemia, prolonged, mainly after binge alcohol drinking. There's a possibility of hypoglycemia. It affects the liver. There's not form. The formation of sugars have reduced. The glucose have reduced. Alcohol and person has not taken food, has taken only alcohol. Gluconeogenesis is affected, leading to hypoglycemia. Illness and comorbid condition, like very critical condition, illnesses, patient in sepsis, ICU, that itself can cause hypoglycemia. Liver or kidney dysfunction, yes, can cause hypoglycemia. Malarial infection is known to cause hypoglycemia. Even the drug used to treat malaria, the quinine, that also can cause hypoglycemia. Malnourishment, it has been reported in patients with anorexia nervosa. The patients, sometimes don't eat because they want to remain slim. So that leading to later malnourishment, and that can also cause hypoglycemia. And there's intake of carbohydrates is not there, or it's poor. Cortisol deficiency, which is also, it has a big role in the hypoglycemia management. Malignancies. So certain patients with like non-islet cell tumors, hypoglycemia is most often due to tumor production of insulin-like growth factor. So you have insulin-like growth factor, which acts like insulin, eats up all the glucose, or digests all the glucose. And in a way, then you can say that certain malignancies can cause hypoglycemia. So what are the levels of hypoglycemia? All these are from a very, very trusted source. So I don't know if you have heard of UpToDate. It is one of the latest that clinicians follow on any medical condition that they need to read upon. So this quite a lot of slides are from UpToDate. So levels of hypoglycemia. So you have level 1, 2, and 3. It's very simple. 70 and 54 are the numbers to remember. If it is less than 70, but more than 54. So that is your alert level. You need to really see if the patient will go into hypoglycemia. Blood glucose level less than 54 indicates serious hypoglycemia requiring immediate action. It typically is associated with some cognitive impairments. The patient might say, I'm feeling a little dizzy, I'm not feeling well, feeling palpitations. Level 3 is severe. That is, he requires the assistance of another, but he is probably collapsed. You might have to administer carbohydrate, glucagon, or even other resuscitive actions. Maybe he's like an unconscious patient, requiring the assistance of another person. Level 1, 1754. Level 2 is less than 54. Level 3 requires the assistance of another person. That's all the key points from these slides have been updated in red. Clinical classification of hypoglycemia. So there are 4 clinical classifications of hypoglycemia, where you have documented hypoglycemia. So what happens is, if there's a glucose level, blood glucose level that's less than 70 milligram, so it's a documented, and the person has typical symptoms of hypoglycemia. Feeling uneasiness, palpitations, feeling of dizziness, feeling of impending doom. So all those are, symptoms of hypoglycemia. So symptoms plus a documented value less than 70. The second one is asymptomatic hypoglycemia. Even though the sugar levels are less than 70 milligram per deciliter, but there are the patient is fit and fine and absolutely no symptoms of hypoglycemia. This can progress to a documented symptomatic hypoglycemia. So this should alert that he should take some snack or something like that, something good in calories, so that it can come up. So asymptomatic hypoglycemia, less than 70, but no symptoms. Documented symptoms, less than 70 plus the symptoms. What are the next 2? You have probable symptomatic hypoglycemia. Patient may feel the symptoms, but he has not measured the sugars. He didn't have a glucometer to measure, but he's saying, I'm feeling dizzy, I'm feeling, I'm feeling a little unconscious, and I'm feeling palpitations, impending doom. However, once I eat something, I become absolutely normal. So that is probable symptomatic hypoglycemia. You have not measured the sugars, but with the symptoms, you ate something, you ate you ate some sugar, a candy or a chocolate, and then you felt better. That was probable symptomatic hypoglycemia. And this last is a pseudo hypoglycemia. That is, it reports some symptoms of diabetes, and even with the person with diabetes reports typical symptoms of hypoglycemia, but the sugar levels are above 70. For him, you should understand the 70 and 54 are numbers, but not everyone at that sugars can have symptoms. So even though they've looked at a lot of studies, they've come to this consensus, okay, less than 70 and more than 54. So considering it as a hypoglycemic blood glucose value. But there are some subset of patients, even above, little above 70 also, they feel hypoglycemic. For them, the normal might be 90 or 100. So they can also be called as pseudo hypoglycemia event, during which the person reports typical symptoms of hypoglycemia, but as a measured level more than 70. Let's proceed. Clinical features of hypoglycemia. So you have neurogenic symptoms and neuroglycopenic symptoms. The neurogenic symptoms are mostly seen in the younger population. If you look at the elderly population, you have more of neuroglycopenic symptoms. That is dizziness, weakness, drowsiness, delirium, confusion, and at lower plasma, seizure and even coma. So this is just a summary slide. Insulin overdose, missed meals, excessive exercise, drugs, alcohol can cause clinical features, sweating, palpitations, tremor, confusion, seizures, or coma. Manage protocol 1, 2, 3, 4. Rapid glucose administration, either oral or IV. Do not administer oral in an unconscious patient. He can aspirate. Frequent monitoring of blood glucose level, identify and address the underlying cause. Administration of glucagon in unconscious patients has shown to be of benefit in about an average of about 16 minutes, 15 on average 15, 16 minutes. Intranasal versus intramuscular administration of glucagon has shown benefit in unconscious patients because of hypoglycemia. Of course, and you have to do the ABC, secure the airway, make sure the patient is safe, vitals are stabilizing, and then manage the hypoglycemia also. So just a slide on drugs other than the that is the diabetic drugs, other than the diabetic glucose lowering drugs and alcohol. Apart from that, that are reported to cause hypoglycemia. The common ones I'll tell you: catifloxacin, quinine, indomethacin, and glucagon also may cause hypoglycemia, which has been administered during endoscopy. So if you can see, there is the moderate quality of evidence is the only one we'll be looking at. Very low quantity and low quality of evidence we will not be looking at for this presentation. Now, what are the strategies to manage hypoglycemia? Identifying the precipitants, risk factors contributing to hypoglycemia. At each visit, your duty is to inquire if it's a diabetic patient. It's very, very important to identify episodes of symptoms consistent with hypoglycemia. Low measured glucose levels, how many times? And these three questions you need to find out, and based on that, you need to readjust the dosing of drugs or even stop the drugs. Episodes requiring assistance of another person, which is stating severe hypoglycemia. Now, how do I reduce the risk of hypoglycemia? What are the key principles? First of all, I need to educate and empower my patients. First of all, patient education, it's important to know that so it's important to know what are the symptoms of hypoglycemia, how to identify hypoglycemia. Frequent measuring, monitoring of glucose levels. You can use this glucometer. Individualized glycemic goals. And rational regimes of insulins or other drugs, you may have to readjust the drugs if the drugs are causing severe hypoglycemia. And of course, regular checkup with the doctor. That is, the patients need to understand that. Yeah. How do I reverse? Somebody's online. Yeah. talking. Okay, how do I reverse hypoglycemia? Now, what are my goals of hypoglycemia treatment? My goal is restore the to normal plasma glucose concentration by providing dietary or parental carbohydrate, specifically glucose. Okay. Cases of severe hypoglycemia, you can administer glucagon to stimulate the hepatic glucose production. Treat early the symptoms of hypoglycemia. When the patient feels tremors, then you should just give him sweetened fruit juice or candy. That needs to be carried by diabetic persons. So that if they feel any symptom, they can quickly take it out and eat it. So consistently effective glucose tablets and patients with type 1 diabetes and those with type 2 diabetes are high risk for severe hypoglycemia and should be prescribed glucagon. So type 1 diabetes have a higher risk of going into hypoglycemia. Why? Because they're on insulin, and that is the reason there's a possibility that they are more prone to going into hypoglycemia if the insulin dose are not adjusted well. Now, what is the monitoring and support? Continuous monitoring address the complications promptly if there's cerebral edema, cardiac arrhythmias, and of course, multidisciplinary approach. Visit an endocrinologist and ICU team in case of severe symptoms. Next, we look at diabetic ketoacidosis. So, an overview slide. Diabetic ketoacidosis is mainly when the sugars have shot up to a very high point. And that the sugars are now, in very simple language, sugar is now converting to bad sugars and causing ketone production, and leading to an acidotic kind of a metabolic acidosis. So three things: because of sugars, ketones are generated, and after ketones being generated, you have acidosis that sets in. Polyuria, polydehydration, small breathing, and acetone breath. So what are the management protocol? You need to replace with IV fluids, insulin therapy, electrolyte management, and monitor for complications like cerebral edema or hypoglycemia. Now, if you look at diabetic ketoacidosis, quickly we look at the the clinical features. It evolves over a period of 24 hours. The earliest symptoms are marked hyperglycemia, nausea, vomiting, some abdominal pain, hyperventilation. As hyperglycemia worsens, there are neurological symptoms and that come in. And common cause of decay include infection, non-compliance to drugs, inappropriate adjustment. Somebody stops insulin immediately, and then the sugars are shooting up to dangerous levels. New onset diabetes mellitus. Many a times, patient presents with diabetic ketoacidosis because he's not aware that his sugars are high. And when he presents with diabetic ketoacidosis state in your casualty, that's when they say, "Oh, the sugars are 500 plus." Then maybe ketoacidosis. And you look at the ABG, and you will assess the vital signs, mental status, volume status. Of course, you need to get the serum glucose. Just follow the red pointer. Ketones, which are above 0.1 to 0.4, it means above that is ketones are present. One creatinine levels and any electro ECG, of course. Decay is characterized by hyperglycemia, elevated anion gap, metabolic acidosis, and ketonemia. Dehydration and potassium deficits are usually very severe. So you will have to look at a lot of things. You'll have to look at sugar values. You need to look at the electrolyte imbalances, ABG. So sugars, serum glucose usually greater than 250 and less than 800. In certain cases, insulin given to prior to emergency department oil, the glucose may only be mildly elevated. Sometimes patient may have presented ketoacidosis at home. The family member would have given insulin, and that time the sugars may not be that high, but that does not reveal the factor that the patient does not have diabetic ketoacidosis. Now, what is the management? If you look at the management part, you're stabilizing the patient's airway, breathing, stabilizer, large IV bore, cardiac monitor required, monitor serum glucose every hour, and basic electrolytes you need to keep checking every Q4 hourly at least until the patient is stable, and treat the underlying cause of decay. Is it pneumonia, urinary infection, MI, or even any form of sepsis? So how do you start off the management? You have to give several liters of, because patient is present in dehydration. You have to give IV, a 0.9% saline as rapidly as possible to patients presenting in shock. IV isotonic 15 to 20 ml per kg per hour. That's about 1 to 1.5 liters. And for the first few hours, till once a patient hypovolemic patients, with you need to give in those. But make sure those patients don't have any underlying cardiac compromise, because cardiac output, if it is low, you may not be able to resuscitate with so much fluids. The patient can go have pulmonary edema or fluid overload. So once the intravascular volume is restored, then you can switch to N/2 saline and check for the sodium, and if the serum sodium is reduced, you can do, and add dextrose to saline solution like a DNS. The serum glucose becomes less than 200, because you need to have insulin infusion to start out. So you need to even replete the potassium. Usually they have large potassium deficits. So looking at these three things, less than 3.3, 3.3, 5.3, and more than 5.3. The hold the insulin part, give up less than 3.3, because they can cause arrhythmias. So very important, you need to correct the potassium. Give potassium chloride 20 to 30 milligrams per liter of IV fluid. Maintain serum potassium between 4 to 5. Once the serum potassium is high, do not give potassium, but keep checking every 2 hourly. Delay administration potassium chloride until there is the serum potassium has fallen less than 5.2. Insulin given as an infusion. But for patients less than 3.3, hold the insulin. Don't give it, because once insulin will cause further hypoglycemia. So whenever a patient is given insulin, it there's this potassium that's being pushed into the cell, and the serum potassium comes down. So if it's already less, don't give further insulin thinking the sugars are high. That will worsen the condition. Give regular insulin with more than potassium 3.3. And in IV infusion 0.1 mg per kg. And if serum glucose does not fall by at least 50 to 70 in the first hour, double the rate of infusion. You want, and every hour you're checking sugars so that the patient does not go into hypoglycemia. If by first hour it does not reduce, at least fall by 50 to 70 milligram per deciliter, double the rate. Once the serum glucose reaches 200 or 180, decrease the infusion rate. And also you may have to even switch to a N/DNS solution. Once the ketoacidosis is resolved, you can switch to subcutaneous insulin. Till then, it's IV insulin that's there. Management of decay, I had put it in detail. So IV fluids, I'm not going to, I'm just this very nice algorithm which I found. I thought it'll help you in your one. So it starts off like this and then goes like this. This is for IV fluids. And so you determine the hydration status. Serum Na is high, then you give N/2 saline. If it's normal, also give N once it's hydrated. If the serum sodium is low, give 0.9 NaCl 250 to 500 ml per hour, depending on the volume state. It's the same thing here. And once the serum reaches 200 glucose, then switch to an N/2 with 5% dextrose. Check electrolytes, ABG, 2 to 4 hours until stable. So this was IV fluids. This for potassium, again mentioned, which I put in the text. Insulin and the need for insulin. Need for bicarbonate. If the pH is less than 6.9, then you give infuse over 2 hours bicarbonate. Otherwise, more than 6.9, there's no role of bicarbonate. If you look at insulin, just follow the pointer. Insulin IV route or uncomplete decays, subcutaneous route can also be given. But sick patients, decay, give the IV route. The same thing which I had gone through in detail. This is given in a more pictorial format by UpToDate. And it's a wonderful algorithm that is mentioned, very readable. So decay diagnostic criteria, more than 250, arterial pH less than 7.3, bicarbonate less than 18 milliequivalents, and at least moderate ketonuria, ketonemia. On normal laboratory values may vary. Of course, you need to check with your own labs for the electrolytes. Hyperosmolar, hyperglycemic state. I've taken these two together because the management is kind of on similar lines. I'm not saying exactly same. So severe dehydration, altered mental status, hyperglycemia without ketosis. So when there's no ketosis, it's possible hyperosmolar, hyperglycemic state. Aggressive fluid, insulin therapy, lower doses than DKA, of course, in electrolyte balance and monitoring for complications. Here I've taken only the chart. So if you look at the left-hand side, it's IV fluids and insulin. Again, the same way it's going severe hypovolemia, looking at the volume status and the cardiogenic hemodynamic monitoring process need to be checked and determine hydration status. Again, the same serum sodium high, normal, or low. Then looking at the insulin, IV regular insulin, 0.1 as IV bolus, then 0.1 per kg per hour as an infusion. Serum glucose does not fall by 50-70, double the insulin dose. The same thing I've carried on from here, the continuation of this on the left-hand side. If the serum glucose does not fall, double the dose. But when serum glucose reaches 300, reduce the regular insulin infusion. Keep serum glucose between 250 to 300 and until the patient is mentally alert. Because if you push to hypoglycemia, you will not know whether the patient is because unconscious because of hyperosmolar reason or hypoglycemia. Of course, you need to check for electrolytes, bun create glucose every 2 to 4 hours until the patient is stable. Glucose levels more than 600, arterial pH greater than 7.3, serum bicarbonate more than 15. So it's almost kind of opposite of the criteria is opposite of DKA. Minimal ketonuria and normal lab values may vary. Now we look at after the sugars. Now we look at something related to thyroid, myxedema, coma. I hope you all are understanding. If you could just put it in the chat box. I know it's a little concentrated version of the slide, but this is an all inclusive slide where you can look at cover emergencies in one slide and very good for exams. So if you look at myxedema, coma is defined as severe hypothyroidism. Means thyroid is hypothyroid, TSH is high, okay, leading to decreased mental status, hypothermia, and other symptoms relating to slowing of functions in multiple organs. It's a medical emergency with a high mortality rate. So myxedema, coma should not be underestimated. So you have two major things in thyroid. You have hypothyroid or hyperthyroid. Here we're looking at the endocrine emergency associated with hypothyroidism. So causes, of course, severe hypothyroidism, infections, any cold exposure, myocardial infarction, surgery, or administration of any sedative drugs, especially opioids, clinical features, bradycardia, hypotension, hypothermia, altered mental status. Management, you have to replace the thyroid hormone, that's a IV levothyroxine. Of course, you can't give the oral tablet, patient is unconscious or in a very altered state. You don't want the patient to, as well, not all these, even though it is called coma, it was not really coma. It's a very bad altered stage of the mental status. And supportive care, warming, fluids, vasopressors, corticosteroids, if there's an underlying adrenal insufficiency. Of course, you have to treat the underlying causes, infection or trauma. So what are the important clinical manifestations that we are seeing? The clinical manifestations that we are seeing is neurological manifestations. Electrolyte, we have hyponatremia, hypothermia, hypoventilation, because myxedema, infiltration of the airway is there. Hypoglycemia, that's poor gluconeogenesis. Cardiovascular abnormalities. Hypothyroid patients have diastolic hypertension. Even though cardiac output is reduced and there's a narrowed pulse pressure, there's cardiovascular abnormalities associated with myxedema, coma, and pericardial effusions may be present. Now, how do I make a diagnosis of myxedema, coma? Of course, first of all, it's a rare presentation. Don't wait for the reports of thyroid, TSH, and then start reading. A very good history taken from the family members often reveals the symptoms of thyroid dysfunction. Of course, they have been followed by progressive lethargy. This is a very important line that I put in. lethargy or stupor or coma. Hypothermia, hyponatremia, and hypercapnia. These three words, hypothermia, hyponatremia, hypercapnia, in a setting of underlying hypothyroidism. Then you have to, and the patient comes in with altered behavior, mental confusion. You make the diagnosis of mixed edema coma. Diagnosis of mixed edema suspect, blood samples should be drawn prior to treatment. You should not give your levothyroxine and then, because the reports will be normal otherwise. So prior to treatment, look for TSH, free thyroxine, follow the red dot, TSH, free thyroxine, and cortisol. And of course, rule out sepsis, which can alter the diagnosis. The serum TSH concentration may be high, indicating primary hypothyroidism. Just to keep it very simple, of course, there is even central hypothyroidism, but most patients who present have a primary hypothyroidism. Serum T4 very low, TSH will be high. Now, how do I treat? The treatment is very good in the sense if you're suspected, it should be instituted without waiting for laboratory confirmation, because by the time mortality is quite high, so start the treatment first. Supportive measures, mechanical ventilation if required, ICU, and of course mechanical ventilation by somebody senior preferably, because you might have an airway inflammation or difficulty. Correction of hypothermia, fluid electrolytes management, and treatment of underlying infection. Hypotension is corrected. It's not a hypovolemic that you need to give, because if it's a cardiac involvement, so you might have to refractory hypotension. You have to even think of giving vasopressors, glucocorticoids. Until the possibility of coexisting adrenal insufficiency has been excluded, you can try glucocorticoids also. And thyroid hormone, levothyroxine, leothyronine. Leothyronine is actually T3. Check T3 and T4 levels in 1 to 2 days, and if just to see if your therapy is working or not. And these are IV drugs. Later only, first you have to give combined therapy as per the latest recommendations. Then you have to plan for, once the patient is stable enough, you can switch to monotherapy of levothyroxine. And appropriate management of the coexisting problems like infection or sepsis. Now we look at pheochromocytoma crisis. Mainly it's a tumor of the adrenal medulla. You have stress and surgery. So those kind of things can actually, any surgery, if it's an adrenal surgery, can cause pheochromocytoma. When you're doing an adrenal removal of the pheochromocytoma, that can also lead to a sudden crisis. Severe hypertension is the important keyword. Palpitations, headache, diaphoresis. Alpha blocker, beta blocker, IV fluids, and definitive treatment is your tumor resection. In this, the management protocol, the very important thing you should know, how do I remember it? Alpha comes before beta. So alpha blockade has to go first, then only beta blocker. Why? Because you have these receptors. That's if you happen to give beta blockers first, there will be there's already a high amount of circulating catecholamines. What is pheochromocytoma? It's actually adrenal secreting tumor that is there. All right, catecholamine secreting tumor. So that is already there in the blood. So there are receptors, peripheral receptors. You have alpha receptors that will cause vasoconstriction and lead to higher BP. So when you give your beta blockers first, what happens is there is unopposed alpha, non-alpha blocking. There's unopposed catecholamines with the receptors. So there's a severe shooting up of BP, which can be even highly fatal. So you need to always alpha first, followed by beta. Alpha blockage first with phenoxybenzamine or diazoxycin, followed by beta blockers. That's your propranolol or corticosteroid. IV fluids for volume expansion. Definitive treatment is your tumor resection. Now, how do I check for whether this can evaluate for and treatment of catecholamine tumors? Suspected catecholamine secreting tumor. Any interfering medications I need to discontinue. You need to check for, I'll give you the keywords only here, metanephrines and catecholamines. first urine metanephrines that they call it. You need to give that and measure. Of course, if it is normal, then you have to recheck during a spell. Means when there's the kind of crisis, you need to recheck. Or normal, or investigate for other causes. If it is twofold, elevation above the upper limit, normal in urine catecholamines, that is your NMET, which we call it as normetanephrine, more than 900 per 24 hours, or metanephrines greater than 400. 900 and 400 is the cutoff that is per 24 hours. Significant in fractionate plasma nephrines. We need to localize adrenal tumors. So you look for any adrenal or abdominal MRI or CT scan you need to. So you have coming onto the right side, the slide goes like this. Typical adrenal or para-aortic mass is present, then you need to plan for an IO-Ben-Guen scan, that is your I-23 scan, if it's more than 10 centimeter greater adrenal mass, or there's a paraganglioma. If it is negative, then reconsider the diagnosis. However, you can always, based on clinicians' clinical judgment, your whole body MRI scan or DOTA PET. In that, if you find some secreting tumor, catecholamine secreting tumor, may not be only on top of the adrenaline or adrenaline gland, can be elsewhere also, the extra adrenal tumors that are there. Consider genetic testing, pre-operative alpha and beta, and plan for surgical resection, because that is one of the best methods where you can treat your pheochromocytoma, but it's quite complex because you need to pre-operatively build up the patient, first give alpha blockade followed by beta. I'm going back to the thyroid again after adrenal, because it's not so common, but yes, definitely you need to know about this. Thyroid storm. So what happens in thyroid storm is untreated hyperthyroidism. Previous myxedema coma was hypothyroidism. This is untreated hyperthyroidism. So you have more that is TSH, of course, it's on the lower side. Your T3, T4 is a higher. Infection surgery can be thyroidal surgery or non-thyroidal. Those could be the causes of a sudden spell of thyroid storm. As you know, a storm usually does not tell it's coming. Okay, it's just sudden. You can just see it coming in and just building up. So like that thyroid storm, you have hyperpyrexia, tachycardia, atrial fibrillation, delirium, or even vomiting. Of course, what is the management protocol? Beta blockers, anti-thyroid drugs, iodine therapy after the anti-thyroid drugs. That is very important. And steroids to reduce the peripheral conversion of T4 to T3, supportive care fluids, electrolyte, and even because hyperpyrexia is there, you need to cool the body. So thyroid storm is a rare life-threatening condition where severe or exaggerated clinical manifestations of thyrotoxicosis. So Graves is often precipitated by an acute event, such as thyroid or non-thyroidal surgery, trauma, infection, or even delivery, parturition. If you look at the diagnosis, I'm just reading the red part. In a setting of all these hyperpyrexia, cardiovascular dysfunction, altered, you shouldn't wait for the report. You should look at the biochemical evidence of in a setting of biochemical evidence of hyperthyroidism. If you have cardiovascular, hyperpyrexia, and altered mentation, then definitely think of thyroid storm. However, there's no accepted criteria as per the latest guideline, validated clinical tools for diagnosing thyroid storm. However, one of it that is followed, as you can see, to diagnostic criteria, but not universally followed. However, up to date gives it, because this is as per up to date, and is one of the very trusted sources. So universally it may not be there, but this is a somewhat consensus of understanding of diagnostic criteria can be used. A score where you look at thermoregulatory temperature, central nervous system, mild, moderate, severe effects, GI effects, diarrhea, nausea, vomiting, abdominal pain gets about 10 points. Severe unexplained jaundice, cardiovascular, looking at the tachycardia part, atrial fibrillation, heart failure, any precipitant history of sepsis or thyroid non-surgicals if it is found. So a score of more than 45 can actually cause, it's highly suggestive. It's not confirmatory, but it's highly suggestive of thyroid storm. Yeah. And score of 25 supports the diagnosis. Score below 25 makes the thyroid storm unlikely. How do I treat thyroid storm? Beta blocker, if not contraindicated, to control the symptoms and signs increased by the adrenergic tone. Thionamide is used to block new hormone synthesis. That's your propyl tyrosine. Iodine solution to block the release of thyroid hormone. The latest, as per July 2024, the latest, as per up to date, it mentions is potassium iodide. You might have all heard of Lugol's iodine, but this one, there's another something known as potassium iodide, iodine iodide. So that solution is good enough to block the release of thyroid hormone. It does not say that whether it is better than Lugol's iodine, but some patients may or may not tolerate Lugol's iodine, and sometimes when you give that orally, there is a possibility of local mucosal injury to the esophagus. Glucocorticoids to reduce T4 to T3 conversion, promote vasomotor stability, possible reduce the autoimmune process in Graves' disease. And if there's an underlying associated adrenal insufficiency, glucocorticoids can reduce it. Bile acid sequestrants may also benefit in severe cases to decrease the enterohepatic recycling of thyroid hormones. Now, the last part of the lecture, that is your adrenal crisis. If you look at it, you have acute adrenal insufficiency, infection, trauma, sudden withdrawal of steroids. Somebody who's daily taking steroids, one fine day decides to stop steroids, then you can have an adrenal crisis. So what is that? Hypotension, shock, abdominal pain, nausea, and confusion. So management protocol, IV hydrocortisone is required because, as you know, the hypothyroid pituitary axis, HPA axis, hypothyroid, pituitary and adrenal axis that is there, that gets affected. IV hydrocortisone is given, fluid resuscitation and electrolyte correction, especially sodium and potassium, and identify and treat the underlying causes. Now, how do I find out whether clinical or laboratory finds suggestive adrenal crisis? Dehydration, follow the red dot. I'm putting it only on the important parts. Dehydration, hypotension, or shock out of proportion to severity of the current illness. Nausea and vomiting with a history of weight loss and anorexia. Abdominal pain, the so-called acute abdominal. And unexplained hypoglycemia, unexplained fever. Of course, you need to think of adrenal crisis, hyponatremia. Of course, you have to look at all those factors together. You cannot just say unexplained fever could be just adrenal crisis. No, that's not what I'm trying to say. What I'm trying to say is you need to associate all the clinical findings together. Hyponatremia or hypokalemia, azotemia, hypercalcemia or eosinophilia, hyperpigmentation of vitiligo, and other autoimmune endocrine deficiencies, hypothyroidism, or even gonadal failure. Now, what is the treatment? I'm looking at the emergency. Establish IV access. Draw blood immediately for serum creatinine, BUN, creat, glucose, electrolytes, cortisol, and ACTH. Again, as it's an emergency, we're talking about only emergency. Do not wait for the laboratory tests. If you're suspecting clinically, proceed with the treatment. Infuse 1 liter of isotonic saline, 5% of dextrose, and isotonic saline as quickly as possible. And repeat the fluid bolus needed for volume resuscitation, followed by maintenance fluids. Frequent hemodynamic monitoring and measurement of serum electrolytes should be performed to avoid any iatrogenic fluid overload. Hydrocortisone is very, very helpful, either if you can, because it has got both mineralocorticoid as well as glucocorticoid activity. Either you can give 100 stat followed by 50 mg every 6 hourly. And if that is unavailable, you can either give methylprednisolone, which is quite easily available, or dexamethasone around 4 mg. Saline must be administered if dexamethasone is given instead of hydrocortisone, and use the supportive measures as required. These are the main emergency methods which have been advised. Now, if you look at the subacute measures, IV saline as maintenance, treat the possible infection, taper parenteral glucocorticoid, and check if you can convert to an oral glucocorticoid. For patients with primary adrenal insufficiency, begin mineralocorticoid replacement with fludrocortisone 0.1 mg by mouth daily. When saline infusion is stopped or hydrocortisone dose is tapered to less than 40 mg. You have to always taper the dose of your hydrocortisone or the steroids that you're using. Now, to complete, early recognition is critical for all endocrine emergencies. That is very important. All these do not wait for the report. Your clinical judgment is saying that it has an endocrine emergency. I have told you essential points in each of it. If there's hypothyroidism with a certain set of symptoms or hypothyroidism in a set of symptoms, then you need to proceed clinically and not wait for the reports. Adherence to protocols ensures effective and timely management. Your mortality rate is quite high, so you need to really, if it can be managed in the correct time, time is a very essential factor in managing endocrine emergency. That's why it's called an emergency. Your time is a critical factor. And after that, you have to educate the patient and the family to understand an emergency, and then how to manage in the hospital, come to the hospital immediately and manage, or what are the home care remedies that can be given. Of course, you need to have an endocrinologist in the loop, have regular meetings with endocrinologists, have clinical discussions with the endocrinology, ICU team and surgeons. Yeah. So we are at the end of the presentation. I know it was quite an intense presentation. And now the floor is open for questions. I hope many of you have understood. No, Gagna, you are not audible.
Gagana, can you try now?
Yes, thanks, Vijay. Alen ji?
Yes.
Yes.
Is my
Thank you.
slideshow over? Is my slideshow over?
Yes. Yes, Alanji. Before we conclude, we would like to open the floor for any questions you might have. Please feel free to type your questions in the chat box, and we will do our best to answer them. Additionally, I'm dropping a link in the chat box for you to fill out and submit to receive your certificate of participation. And also, I'm sharing the link of our WhatsApp channel. Please do subscribe our channel. Follow. Thank Please drop your questions in the chat box. We'll do our best to answer them. I'm just checking the chat box if
I
there
will
is any
take
question.
Dr.
Wonderful
Daniel's.
session. Thank you, sir.
I'll take Dr.
Wonderful
Daniel's
session.
question. Should we follow sliding scale for DK? Well, when the patient presents in the casualty, that time sliding scale cannot be followed initially. First, you have to plan for a bolus dose followed by infusion. After that, only once the patient stabilizes, once you're out of the DKA phase, your diabetic ketoacidosis phase, then you can follow sliding. What happens sliding scale? The sugars are checked every 4 hourly. Here, the sugar has to be checked every 1 hourly, and it has to be managed accordingly. Your insulin infusion has to be adjusted or titrated accordingly. So as I had mentioned, if you don't find it reduced by 50 to 70, you may even have to improve the bolus doses. Yeah.
Okay, we have a question from Dr. Sunanda. Sir,
Yeah.
just for flashcard, how to different... Alanji?
Yeah, I'm here. Yeah, just throw a flashcard, how to differentiate
How
between...
to differentiate HHS and DKA, and in the treatment, what is the difference?
Correct. Just for Sunanda's sake and for the others, I would just reshare my slide again and just go back to the presentation. If you look at management of DK, just look at the underlined box. That is the core crux. Serum DK, serum glucose more than 250, pH less than 7.3, serum bicarbonate less than 18. Plus, you need to have ketones positive in your urine ketones, that is, or blood ketones, that is positive. Urine ketones is very easily available in the casualty. Blood ketones takes time to come. So urine ketone, even if that's positive, it's considered as ketotic. And of course, ABG is on the acidotic side, then you need. So that is your DK. Now, if you look at HHS, the treatment lines are almost on similar lines, but if you look at the HHS, wait. So here you have glucose more than 600. There it was less than more than 250. But here more than 600. Arterial pH more than 7.3. There it was acidotic. Here it is more towards a basic. And serum bicarb, there it was less than 18. Here it's more than 15. And no minimal or no ketones. And normal, so minimal or no ketones. So, and the management wise, what is the main difference in management? It's here. I'm going to use the red spot again, laser pointer. So here in HHS, when the glucose reaches 300, you have to reduce the regular infusion. There, once it reaches 200, then you need to reduce the insulin infusion. And here you keep the serum glucose between 250 to 300 until the patient is mentally alert. Here, what you do, what you can see, it is 200 to keep the regular infusion and keep the serum glucose between 150 to 200 until the resolution of DKA. Of course, in DKA, you have that fruity smell from the patient's nostril, you can see. Yeah, I hope this was more like
Thanks,
a revision.
Yeah, so we have one more question from Dr. Mamoon Rashid. If there is no endocrinologist available in a 3-tier city, is there any telemedicine option available like the teleradiology services?
Yeah, of course, many hospitals do provide endocrinology services by telemedicine, but you need to understand endocrine emergencies cannot be treated at home. Okay, you need to rush to the nearest hospital, and since you are all professional health professionals and nearest doctor that's available, and this presentation itself, I've mentioned whatever emergencies, treatment, basic treatment you need to give till you sort out, that has also been mentioned in the presentation. So if endocrinologist is not available, it is better to have an endocrinologist. Not available, a general medicine or family physician can also treat these emergencies, stabilize the patient, make the patient referable, means safe for travel till he reaches the next referral point.
Okay, thank you so much, Alanji, for answering this question. We have one more question from Dr. Ashad Sharma. Patient is undergoing surgery, and in mid of surgery, suddenly his or her blood glucose is dropped suddenly. What do we need to do? Do you want me to repeat the question, Alanji?
No, it's good. So the thing is, you have to look at it this is mainly the anesthesia point of view, because surgeon is performing the surgery. He is not bothered about the sugars, to be very frank. He's concentrating on his surgery. So based on hypoglycemia, you will have, first of all, why did they do a sugars in the middle of surgery? There are two reasons. They found the parameters going bizarre. Tachycardia, BP is shooting up or down. Patient is becoming unstable in a normal case. They've done the sugars, found hypoglycemia, treat the hypoglycemia. Now, how do you treat hypoglycemia? Of course, you can't give orally because patient is intubated or undergoing surgery. So you'll have to give IV glucose. How much? There's this already pre-prepared 100 ml of dextrose, 50% dextrose that is there to treat the many centers have 25% dextrose. Even that should also do. So about 100 ml of that.
Thanks, Alanji.
Can be infused. And the patient's
sugars
will
Thank you
pick
for
up.
your
Yeah.
answering.
Yeah.
Okay, so the next question is, sir, can you please tell me, can you please tell me the ideal dose of insulin as per sliding scale, as I have found different dose used in different center?
You're absolutely right. There is no obvious this one about insulin sliding scale. Okay, many centers, they practice their sliding scale, but it varies about 50 to 100 unit. 50 to 100 milligram per deciliter, it kind of varies. So that how you actually come to a sliding scale is, first you give bolus dose of insulin, you understand the pattern, how much sugars are actually reducing, how much sugar glucose is reducing when you give X amount of insulin. X units. So when you calculate over 24 hours, and this been studied over a few days, then then you say, okay, if we give this much, your glucose levels are going to reduce accordingly. So that is kind of a general, there's no obvious fixed, you can't call it a fixed sliding scale that has been, mandated and, given, because some centers, the same sliding scale may cause hypoglycemia or may not even reduce the sugars. So it can act on both ends. So of course, it depends from center to center.
Yes. Alan ji, we have a next question. That is, if we don't have an alpha blocker in pheochromocytoma, can alpha plus beta blockers can be used? Here we have an answer from Asha Sharma. That is, metoprolol is a mixture of alpha and beta blockers. Metoprolol is a combination of both.
Okay. So, see, ideally, you need to have a specific alpha blockers, because I'm a surgeon. I do operate on adrenal tumors also. So you should understand one thing. You need to prepare the patient well in advance. It is almost a nightmare if you don't prepare the patient. So you need to somehow give alpha blocker first. Okay, isolated alpha block, not the combination of alpha plus beta. No, you need to give an alpha blocker first, followed by a beta blocker. Yeah, I hope that is clear. If you give, see, metoprolol, of course, it has definitely has cardiac effects also. But I'm telling you, you cannot give that. You need to specifically block the, when you're giving a combination drug, you don't know what will act first, right? Whether the beta blockage of that drug will act first or the alpha will act, because both of them are being given in this. So specifically, you need to go to point A, stop that function, then go to point B. You cannot say, I will take both of them together, because I don't know whether it will act first on the alpha or act first on the beta when you're taking combination medicines. So that is the reason alpha blockage has to be given separately. If it is available, if it's not available, it has to be made available, or the patient has to be referred, because it can become almost life-threatening.
Okay. Thanks, Alanji. Thank you so much for answering the question. We have one more question from Dr. Trivendra Katre. Sir, is there any treatment line to control steroids-induced hyperglycemia? Hyperglycemia, I think it's hyperglycemia.
Is there any treatment line to control the steroids? Okay. So the treatment line is, of course, you need to taper. See, it depends on why you're taking the steroids. If steroids can be reduced, okay, or steroids need to be taken for a short duration, preferably. But certain disease conditions, you need to take a longer duration of steroids. That can actually cause your hypoglycemia. So in those lines, you need to, if it's very high sugars, you may have to even use insulin to reduce your blood sugars. And once the steroid effect use is over, you need to taper the steroids and stop. Okay, if that's possible. If not possible, then you'll have to either use insulin, or even you can use oral hypoglycemic drugs. But if you taper the steroids, of course, you need to taper these also accordingly.
Okay. Thanks, Salanji, for answering the question. We have one last question, I guess, from Dr. Abdul. Sir, why diabetic patient does not feel hungriness?
I think diabetic patients do feel very hungry and craving for food all the time. I don't think does not feel hungry part. I'm not sure about that. But what I understand, polydipsia, polyphagia, and polyuria. So in the very definition of the diabetes, patient starts having passes excess amount of urine more in the night. Starts eating more because of craving of sugars. He wants to eat more and more. So does not feel hungry. He feels over hungry. More craving of
Thanks,
food.
Alanji. Thanks, Alanji. I think there's no more questions. Thank you, sir.
I hope the presentation was good, and
yes,
hope
we
many
have
of you
some
benefited from the same feedback.
Yeah, we have some feedback. Thank you, sir. It's a great session I got today. Thank you for wonderful session. Wonderful session. Thank you. Wonderful session. Thank you. Your webinar is good. Thank you, Dr. Kirtia. Kirtia is a person like, she keeps on attending the webinar. That's why I think she knows your webinars. And we have Dr. Durgesh Kumar has also said the webinar is good.
You
Thank you
can
so much.
also keep the floor open for something, on some topics that the people
Mhm.
want. Okay.
Hmm.
So if
Okay.
anybody wants a particular
Yeah.
topic to be taken as a webinar, that can always be adjusted. So you can just put it in the chat box.
Yeah.
Yeah, and also leave a feedback. Also, I want to
Okay.
bring across a very important point to everybody here, especially the participants. The thing is, we have something new in our thing that, as you know, we have fellowships and diplomas for our students. And yes, definitely, I don't know how many of you have heard of Up to Date. Have you heard of Up to Date? Anyone? Can you just put it in the chat box?
Yes, Prasanna Priya is texted yes.
So it's a very good clinical tool for it gives you a lot of today's most of the presentation, the tables, very lively tables, very easy to understand, readable tables are all from Up to Date. I think, yeah, so yeah, Up to Date is a very good clinical resource for both medical and surgical team. And yes, it gives you the latest, you will not be able to read all the journals, but it's like a summary of most of the journals, latest in that field, and it has a lot of resource. You name the condition and that has it. Of course, it is paid, that is there. And our fellowships and diplomas can be, once you purchase them, we can give you a free access to Up to Date. So yeah, do join
Sure.
our courses and yeah,
Thanks for the valuable information which you shared with them.
just put
Thank
it
you
in
so
your
much.
feedback,
Apart from
whatever
that,
you require webinars, and we will look into it.
yeah, definitely we will be doing webinar on neonatology in coming days. Apart from that, it is very informative. Kindly send soft copy. Also, I have not
Yes, we
received
will do, Dr.
UGI.
Trivandrum, we will do. Yeah, I have
Will
been.
send this Dr. Trivendra Karte. I will talk to the person who is in touch with you, Dr. Trivendra Karte, the PDF of the upper GI bleeding one. Infectious disease we'll be doing as soon as possible. We have already planned for the webinar. That's cool. And apart from that, I think there are no more questions, Alanji. We can wind up the session, I guess.